talking to our friends from the medical field now. Again, ladies and gentlemen, welcome back to All India Radio Houston. I am Dr. Nik Nikam, and now we're going to talk about infertility. Infertility is a very important topic, and my special guests are Dr. Dan Williams and Dr. Kim. Gentlemen, welcome to All India Radio Houston. We are delighted to have you, and
thank you.
You're welcome. Okay, you know, when couple get married, everything is so wonderful. They have a nice vacation, this one, and a couple of years go by, 2 years go by, 4 years go by, and you start hearing some murmurs. First inside the family, then the friends and neighbors. You say, "Oh, when are you going to have a child?" It's not like these people are not trying, you know. Some people are trying everything they possibly can, and they cannot have a child for whatever reason it is, which you, ladies and gentlemen, are going to explain everything about why they can't have and how you can help. These Doctors William and Dr. Kim specialize in helping people, or couple, I should say, with infertility, or people who are not able to conceive a child. So, gentlemen, let's begin with what is infertility and how common is infertility among young couples?
So infertility is the inability of a couple to conceive when they're having unprotected sexual relations.
Yeah.
And at least for 12 months of trying.
I see, 12 months. That's an important point, because as I said, you know, people say, well, we are just only 4 years, you know, we still have a long whole life to go. What's your input?
So, once again, thank you for having us.
We are delighted, yes.
To talk to your listeners. Just like Dr. Williams said,
yeah.
Infertility is defined by inability to conceive a child after 12 months of unprotected intercourse if you're less than 35 years of age.
I see, yeah.
In fact, if you're greater than 35 years of age, we actually recommend that you seek help if you're not able to conceive within 6 months.
6 months, okay. How prevalent is this?
So infertility affects approximately 15% of couples of reproductive age. So
You're
that's
kidding.
a fairly large number.
Are you sure?
Yes.
You're scaring me.
No. The good news is that most patients will ultimately be able to conceive.
Yeah, if you can get a little bit closer to the microphone. Yeah.
So the good news is that even though it affects 15% of couples, most couples will ultimately be able to successfully conceive either with or without assistance.
Oh, okay. So that's much more encouraging. I know I was looking at some of the data from CDC. It's anywhere from 6 to 15%, and I guess this goes up with age, right?
Absolutely.
Infertility. Okay. So what are the most common causes of infertility, or not being able to conceive a child? Let's start with females. So I guess it affects both men and women, right?
That is correct.
For the general public who think that, well, it's just female problem. Let's talk about females. What are the most common causes which leads to infertility?
So I'll start with the female, and we'll have Dr. Kim go over the other important half.
Yes.
So for females, what we see is there's really three major categories. Failure to ovulate, or an egg problem.
To produce eggs.
Yes. And the second would be tubal blockage.
Where the egg cannot get into the uterus where it's fertilized.
So basically the tube is how the sperm gets in to reach the egg when it's picked up by the tube.
Oh, okay.
So if the tube is blocked, the sperm and egg cannot connect.
Oh, okay, that makes sense.
And then the last, interestingly enough, is unexplained infertility. That means the female partner ovulates, her tubes are open. And, of course, the male's part, which Dr. Kim will talk about, has been normal as well.
So these are the only two main categories then.
Oh, sorry. Well,
producing the eggs and not being able to fertilize the eggs.
Right.
So, right.
So we usually say there's an egg problem.
Oh, I see.
There's a tubal problem.
Yeah.
And then unexplained. Now, there are some other causes, endometriosis, that are less common, but those are the three big ones.
That's very good. Kim, let's talk about men.
Sure. So, like as you suggested, the males are very important other half of the couple.
Yeah.
You know, I always caution my patients that Usually, infertility stems from both male and female combined. About 33 to 40% of the times, it's some female factors contributing, as well as some male factors contributing to each other.
So when you start seeing this couple, and how many what percentage of men say, "You're crazy. Why you want to test me?"
It's a fairly high proportion, but the common causes of male infertility are very similar to females. It could be anatomical, where the vas or the epididymis or some kind of tubal, or there could be a male tubal blockage prohibiting the sperm from entering.
Females.
Exactly.
So, are we talking about the vesicles or the tubes that carry the sperm?
The vas deferens or the epididymis. It could be hormonal in nature. So they could have the same thyroid, prolactin issues.
I see.
It could also be testicular failure leading to low testosterone. It could also be other medical problems like diabetes. That's creating other sperm transportation issues. It could also be actually idiopathic or unexplained as well. One of the more common problems that we're seeing now is with males with slightly decreased libido, where they actually get prescribed a dose of testosterone.
Everybody in town is getting testosterone.
Right. The only thing that we caution is that testosterone will suppress the natural testosterone sperm production within the testicles. And it actually may lead to subfertility or infertility. So we actually recommend that if you're actually trying to conceive and you have to be on testosterone, that it comes from a fertility specialist or those who work exclusively with male infertility.
That's very interesting. Ladies and gentlemen, you are listening to Dr. Williams and Dr. Kim. We are talking about infertility, which may involve both the female and the male partner. And before we go any further, let's give out your practice locations and, where are your office located and what hospitals do you all practice at?
Well, we're with Houston Fertility Institute, or HFI for short, and we actually have 10 office locations in town. So we go as far as Woodlands, Willowbrook, all the way down to Clear Lake, Sugarland, Medical Center, Katy. So our website actually would list all of our locations.
Okay, let's give out your web address.
It's www.h as in Houston, f as in fertility, I as in institute, -ivf.com.
IBS.
IVF.
Yeah, intrauterine. What's it? Intrauterine
in vitro
fertilization. Okay. IVF. Okay. Let's talk about. We talked about how long should the couple wait, before they seek help, and you said, 12 months, and if they are more than 35 years old, maybe even 6 months. Okay. No, everybody's reluctant to come, but anyway, the neighbors, the family members, and the brothers, sisters, everybody have convinced this couple. Maybe the man is not sure yet. So, this couple are sitting in the office. Where do you start?
So, initially, when the couple comes into your office, you want to get a basic history from both partners.
Yes.
And the first thing I ask them is, I assume you guys are ready to try to have a baby. Of course, you want to make sure that that's definitely
They're not in a wrong doctor's office.
But nonetheless, you get a history from both partners just to tip you off to any issues that might cause a problem. And then from there, you simply will talk to them about the general workup, which Dr. Kim can go over.
Okay, let's talk about, you took the history, you examined the patient, and what kind of tests do you do for men and for women? So let's start.
So for males, the easiest test we start out with is a semen analysis.
I see, yeah.
So we generally ask the male partners to be abstinent or refrain from having intercourse or ejaculate within 3 to 5 days or so. Give us a specimen. We'll look at the motility, concentration, volume, morphology of the sperm, and kind of determine where they lie in the grand spectrum of their fertility. In terms of the females, we start working up what Dr. Williams mentioned before. We want to make sure that their fallopian tubes are patent or open. We want to make sure that uterine cavities are free of debris, like polyps or fibroids. We want to make sure they're ovulating. We want to make sure we optimize their other hormonal issues like thyroid, prolactin. And we'll also do an ultrasound to make sure that the ovaries actually have follicles within them, and that we don't see any fibroids or the benign tumors within the uterine walls that could impact their fertility.
Okay, let's go back to females then. And how do you determine if they're producing ovaries?
Okay, so here's the thing. We want to know,
Yeah.
obviously, if they're ovulating, but even more importantly, are those eggs good?
That's
So to determine that, it's very, very simple. So every month, the group of eggs start growing. One's going to ovulate, the others die off. Humans make 1 egg a month.
Yeah.
You want to know the number of eggs that are ready to start growing each month, and that gives you an assessment of the overall count. So you do a simple ultrasound while they're on their period.
Oh, I see. Yeah.
And you count the number of follicles, which are the cysts with eggs inside.
So you can see those little cysts. How big are these cysts?
3 to 8 millimeters.
3 to 8 millimeters, and you'll be able to see it on the ultrasound.
Yes,
you must have a pretty high precision ultrasound test.
Yes, we do.
Like almost like an electron microscope, right without cutting the patient.
The resolution is good,
Really?
and we're able to do a count.
Yeah, because to me, I want to emphasize this because when people come, they always worry, you want to put instruments, you want to do surgery and all these things, but there are tests which can just do it in the office setup.
Without actually doing anything invasive. Now,
yeah.
The second thing is that's just quantity you want to know, so quote-unquote quality, so you do 2 blood tests. It's 1 blood draw, but one hormone is your brain hormone, the FSH, which helps to stimulate your eggs to grow, and the other is AMH, anti-Müllerian hormone, which comes directly from the cells that surround the egg, and that gives you an assessment of the quality.
Okay. Now let's talk about, Kim, how do you determine if their tubes are open or not?
So there are many different tests that we can do.
Yeah.
There are advantages, of course, and disadvantages to each test.
Yeah.
One is an X-ray test called hysterosalpingogram, or HSG.
Yeah.
We perform it in an office setting where we place a little bit of dye into the uterine cavity.
Yeah.
And we determine whether the tubes are open or not. It's an excellent way to see if the tubes are open, but a very poor substitute to actually evaluate the uterine cavity.
Yeah.
Another test that we can perform is something called a hysteroscopy. Under just a very little bit of light sedation or anesthesia, we'll actually place a small telescope lens inside the uterine cavity. We'll actually look at the cavity and actually evaluate the tubes that way. The advantage of that test is that if there is anything abnormal, we'll just take care of everything at once.
Oh, I see.
And
it's like a procedure with a treatment plan in place.
Yeah, exactly.
Oh, okay, that's very good. So, ladies and gentlemen, you're listening to All India Radio Houston. My special guests are Dr. Dan Williams and Dr. Kim. We are talking about infertility, where couples cannot conceive a child and what options they have so that they may be able to produce a child. Okay, now we talked about what causes infertility in both men and women. We talked about how to diagnose some of the most common conditions. Now let's talk about what specific treatments are available for men. Kim, you talked about sperm analysis, and if you find something wrong, how are you going to fix it?
So it depends on the degree of the abnormality.
Yeah.
We have different options. We can use medications to boost up sperm count if that's necessary or if that's possible. If the semen parameters are subpar for even medication treatment, we can approach it using artificial insemination or insemination, or we can do in vitro fertilization, where we actually place the sperm directly into the egg to create an embryo.
Yeah. Oh, okay. Are there such a thing as sick sperms, or sperms that are really not functional? Besides the sperm count, which you talked about?
There is. So, one of the parameters that we check during a semen analysis is morphology. So the way the sperm appears under the microscope. So we have very highly trained andrologists who do literally thousands of these a year.
Is that right? Yeah.
And they'll actually look at the sperm head, the sperm midsection, the sperm tail, to make sure that the head shape is normal.
Yeah.
Make sure they don't have 2 tails, 2 heads. And that actually predicts the sperm's ability to fertilize an egg effectively.
So what do you do for those people who may have an abnormal sperm?
So if they have abnormal sperm, that's a reflection of the quality of the sperm.
Yes.
If it's subpar, then typically the right treatment is in vitro fertilization with intracytoplasmic.
But you get sperm from a different donor?
No, not necessarily. We can actually circumvent that by doing something called ICSI, or intracytoplasmic sperm injection.
Oh, is that right?
So we'll take the sperm, actually inject it directly into the egg, and actually fertilize the egg.
This is all new to me, but at the same time, it is also kind of sort of pleasing to hear, because people always worry, well, if I can't produce a child with my sperm, maybe I'm less of a man or something like that.
No, but at our facility, we've done in vitro fertilization for males who literally have 10, 20 sperm.
Is all right? Oh, these are very important points to encourage people to know that they still have a lot of options and hope to have a child from in many different angles. Okay, let's talk about what specific treatments are available for women. Then,
well, so for the female partner, in fact, it's very important to note that even if it's a male factor, all the treatment involves the female partner because she's the one that actually gets pregnant. So usually when we're doing treatment, we want to increase the chances for conception. We do that by increasing the number of eggs. That means we use fertility medicine typically to do that. And then putting the sperm and egg closer together. And that would be either injecting sperm into the uterus insemination or the in vitro fertilization that Dr. Kim was just discussing. Now, in some cases, patients will have surgically correctable issues where their tubes may have some scar tissue. We can clear that to help them get pregnant. Scar tissue in the uterus that we can actually surgically correct through a little telescope in their uterus. So there are surgical interventions as well as medical interventions. As I said at the beginning, most patients will ultimately be successful.
See, when you use fertility drugs, one of the major concerns people have is, you're artificially trying to create something. Is that going to create abnormal babies or malformations?
Well, there's two things to that. One is when you do insemination, when we put the sperm into the uterus, fertilization happens in the body naturally. So that's the first point. The second point is when we do in vitro fertilization, some studies have actually shown a small increase in birth defects, but it's very small compared to the number of IVF cycles done, and not all studies have actually shown it an increase, and therefore it is thought that that small increase is due to the underlying infertility cause as opposed to the treatment.
So there's a lot more benefit in taking these medicines. So
absolutely.
So you can be, you can have a child. Okay.
And the only thing I'll add about the medications is that, like Dr. Williams mentioned, we're giving FSH and LH hormones, which are hormones that your body would have made.
Body already makes it. So you just kind of supplementing what may not be adequately.
It's nothing artificial or anything that we've created, but rather it's just something that your body makes.
People are scared of taking all these medicines, like cancer drugs or like transplant drugs. They have serious side effects. And okay, let's continue with our ladies and gentlemen. You are listening to All India Radio Houston. I am Dr. Nik Nikam, and we are talking about infertility. And my guests are Dr. William and Dr. Kim from Houston Fertility Institute. Okay, very good. Let's continue here, and let's talk about. You talked about some of the hormones that you use, FSH and the other things. What are the medicines you can use in male or female patients? I have seen that there are some other medications that may be used in these patients to boost their chances of getting pregnant.
So metformin would be one medication that's used.
You mean the diabetes medicine?
Absolutely.
You're kidding me.
Well,
how does that work?
So you've heard of polycystic ovarian syndrome or PCOS. It's a very common condition in which a woman does not ovulate and makes excess male hormone. They also have associated insulin resistance. Therefore, taking metformin lowers their insulin levels. That lowers their male hormone levels, and in some cases will help them to ovulate on their own. If it doesn't help them to ovulate, it can help the fertility medicine we give work better in some cases.
Okay. Now let's move on to some of the more, I wouldn't say advanced, the next step of realm of treatment, and that's assisted reproductive technology, or ART. So, Kim, you want to start off? What is ART? And let's cover in depth what are the different types of procedures or approaches you have in this circle.
Sure. So ART, as you said, stands for Assisted Reproductive Technology. It's a general term that we use to it's an umbrella term that we use to describe what we do to help couples conceive. The two examples that I've already given, one, artificial insemination or intrauterine insemination, those terms are interchangeable, where we place the sperm into the uterine cavity. And the other is in vitro fertilization, where we will fertilize the or create an embryo outside the body and place the embryo back into the uterine cavity.
I see. So in other words, you take the egg from the female and the sperm from the person, and is this the same thing as a test tube baby?
Sure.
Huh?
It is. It is.
Okay. What other types? I saw there were like 3 or 4 different ones.
So the other ones you have listed there are GIFT. GIFT actually is it's an acronym. It stands for gamete intrafallopian transfer, and what that simply means is for couples, say that would not religiously allow fertilization outside the body, meaning in the lab, we can actually take the eggs, then put a sperm together separated by air in a little catheter, inject the sperm and the egg droplet into the uterus, and therefore you still allow fertilization to happen in the body, but you're actually concentrating the eggs and the sperm there. So it allows a better chance for conception. We don't use that very much anymore because the in vitro fertilization is much more effective and does not require a procedure to put the sperm and egg into the tube.
Okay, here's my next question. I come from a cardiology background, and if you got a blockage, you put a wire, you put a stent, a balloon, and open up the tube, everything should be fine. You can get back to work tomorrow. Why can't you do that with the fallopian tubes?
So it actually depends on the location of the blockage and the extent of the blockage.
I see. Yeah.
If it's a proximal blockage, that is something that we can do. And
do you all put stents?
We don't put stents in. The reason is that any foreign body
within
the fallopian tube or within the uterine cavity will actually lead to an ectopic pregnancy
or
pregnancy within the fallopian tube, which actually can be a life-threatening condition.
Block the movement.
Exactly.
Okay,
typically, like I said, for proximal tubal blockage, that is something we can try. For distal tubal blockage, where the blockage is towards the end of the tube, towards the ovary, that procedure is not as successful. Typically, they are due to previous pelvic infections or endometriosis. And the problem with that is that even if we were able to surgically correct those tubes, they will reclose. So with in vitro, it is just a better chance of success.
Again, coming back from my cardiology perspective, because cardiac bypass surgery is based on the fact that if you have a blockage in the middle of an artery, you bypass the blockage with a vein graft. And is it something that is feasible if you have a blockage in the middle of a fallopian tube? Maybe you can bypass that blockage with a graft or a vein?
I think I can address that. So the cause of blockage in the heart is usually plaque buildup, atherosclerosis. In the tube, it's more scar tissue. So usually when Dr. Kim said, we use a similar guide wire in a very small catheter to actually sort of open up or clear the channel, and then you flush out the tubes. Now you're relying then on natural hormones that the patient makes herself, i.e. estrogen, to help heal everything over, and then you try to take advantage in the first 3 months to get pregnant.
Oh, okay, so now, you have the couple, you have already tested, and you've done some kind of a intrauterine pregnancy procedure, and what do the couple do? Sit and wait? What is the success rate?
So the success rates are going to vary. Obviously, if we do something like insemination where we just put the sperm there and let everything happen in the body, the success rates are not going to be as high as if we actually combine everything in the lab and grow the embryos in the lab and then put actual embryos back into the uterus. So in a couple under 35 should have the highest success rates because it is based on age. Women under 35 in our program will typically have a 20 to 25% chance to conceive with insemination. It's 68% with in vitro fertilization. So there is a big difference.
That's pretty encouraging. So what happens if they don't succeed the first time you try it?
So what you're really asking is how many times can they try before their success rates drop, and generally that number is 3 cycles. 3
cycles. Okay, very good. And as you said, that the couple's age also makes a difference, right? If they are in their 30s or mid-30s or 40s, what happens to the success rate?
So that is true. So studies have shown that the actual peak fertility is between ages 20 and 24. Starting at 32, we do see a slight decline, or gradual decline in the woman's ability to conceive. And starting at 35, that process, I guess, accelerates. And the reason is simple. Starting at 35, both the egg quality and the quantity are declining. And that's kind of the underlying driving factor in what we see.
Gentlemen, this has been a very lively discussion because I learned a great deal, and I see a lot of hope and promise from what you're describing to me in terms of how much you can do to these couple who are not able to conceive, compared to what my perception was before I started doing research on this particular topic. Again, let's give out your clinic information and contact information so that if somebody is interested in learning more about infertility and trying to get an idea as to how they should approach this problem.
Sure. Once again, our website is www.h as in Houston, F as in fertility, I as in institute, hyphen IVF.com.
V is like Victor.
V as in Victor, that's correct. And on the website, we actually have patient information available for different procedures and different services that we offer.
So you have a lot of information on the website. That's great. Okay. A couple of more questions. We are almost. This has been so interesting conversation for me as a cardiologist. We already spent 28 minutes. We got a couple of more minutes left. Anyway, let's talk about what are the drawbacks of some of these treatments we've been talking about, the drugs, the procedures.
Well, certainly there's always an underlying stress involved with not being able to conceive. Certainly. The biggest side effect that we would actually notice is multiple gestation, and we do ultrasound to follow the number of eggs when we're doing insemination, or we control the number of embryos we place back to try to limit that to twins only if you're going to have multiples.
Gentlemen, I have to tell you, we are just about out of time. Dan Williams and Kim, it's been a pleasure talking to you. Maybe we'd like to get you back again so that maybe we can cover in depth some of these things. Because for those couple who are going through this a tremendous emotional aspect involved. Because that's what the people feel, the family feels, their friends feel. We haven't even touched that surface. Anyway, thank you very much, and thank you for being on All India Radio Houston. Thank you.
Thank you. We enjoyed it.